Well, good morning. Now that it's 10 on the dot, we will get started. Um, this is the Healthcare Data Governance webinar that I and Heather Hicks here will be presenting to you today. For some housekeeping rules, know that you can put anything in the chat. We've got Carrie Parker here and Christy Gagne that will be watching the chat and letting us know if you have any questions. Also, you can come off mute. We do have question and answer at the end, so we will allow for questions at the end of the presentation. We would love to see your face. If you can't come on camera, that's great. Knowing that you're here is great. But please make sure you keep yourself muted through the entire presentation, and we will take questions during the presentation if you put them in the chat, and then after. So like I said, my name is Maria Hensley. I am the Health IT and Reimbursement Specialist here at Community Care Network of Kansas. I am with my coworker, Heather Hicks, who is the Quality Improvement Specialist. I'm sure you all know us by now. And we are going to be going over some data governance. This has become a big concern, a big item that we're all looking at probably in the last year or so, especially with the use of AI coming about. To see where our health centers stand when it comes to data governance and how we manage our data. So what we're going to be going over is what actually is data governance. So we're going to start from level one. We're going to start at the basics and talk about what is data governance, why is it important, and who is it involved. So what roles of our health center need to be involved with our data governance. We also are going to talk a little bit about AI governance, which is very similar, the data lifecycle, and next steps. So getting right into it, what is data governance? Data governance, what we do with our data, what can we do with our data, how do we store our data, who sees our data, all of this combined. It's a collection of policies. So most of us have policies and procedures that surround our data that tells us and our patients where our data is housed, how it is viewed, and how it is used. And this is the most efficient way of how an organization can achieve your data goals, whether that's by quality, risk management, it can be a plethora of reasons. And how it's supported. What is supporting our data? A lot of us have Azara drives. Some of us have Power BI, other platforms that have our data in it. How does the state use our data? We have interfaces with WebIZ and Kanza, the HIE. Where's our data? How is it stored? How is it processed by other software and services? And how it's critical when it comes to strategy. So we all have a strategic plan. How is our data influenced by our strategic plan? Or how is our strategic plan influenced by our data? So all of this combined goes into our data governance.
So why are we talking about this? Why do we need this? And what kind of prompted this? And I think it's a little bit of everybody in their role has an idea of what data governance is to them. And that's not wrong. But sometimes what one person is working on data governance doesn't see another role's part in data governance. And so sometimes that makes it piecemeal, and it's not a uniform, overarching organizational approach to data governance. Because data governance isn't just, are my labs where they need to be? Are my financials going into the reports they need to be? Are my roles set up the way they need to be? And are my employees who are no longer with me not here? And what about the credentialing files? All of that is a piece of data governance, because every piece of data that we have needs to be governed by the data governance policy so that all of the data is where it needs to be in a usable way. And so there's several different things that go into this. The first one is accuracy. We want our data to be trustworthy. We want it to be our friend that always tells the truth, and we may not want to hear what it has to say, but we trust that it's telling us the truth. And that's what data governance does as far as accuracy. It makes our data tell us the truth. And then we can trust it. Our staff can trust it. Our patients can trust it. It's not just that it's technically accurate for clinical care, but it's also accurate for operational decisions. It's accurate for risk management work. It's accurate, and that improves the efficiency of good clinical care, not just the accuracy of clinical care. So the information itself needs to be accurate, but also where that information lives in the system needs to be accurate. Security, we hear a lot about security. We don't want anybody else out, getting into our information. We don't want those hackers or anything like that coming in and messing with our stuff. And that's true. That's accurate. But also, it's part of managing our data to ensure that the staff is secure from us and our staff. So there's not just external actors, there's internal actors, and sometimes we are our own worst enemy. A robust data governance program doesn't just have, you're in charge of this piece and this role has access to these permissions, but it also controls how the data is entered and who can make changes to where that data is put in and maps where that data comes from, where it lives, where it's used. It's ensuring that our interfaces are populating where they need to be. It is ensuring that we have our accesses set to where people can't accidentally change a template that's being used to drop code somewhere. So that security goes beyond just keeping it from being hacked or ransomware or anything. It keeps the data safe from us as well. And then consistency. We all have our favorite restaurant, right? And we go in, we get our favorite thing, and it's the way we expect it to be. And that's, we have our family recipes, or we have our favorite blanket for book night, and we have expectations around that. And you go to your restaurant and your favorite thing is gone. Or, then that's not your favorite coffee shop anymore because mocha midnight latte went away. So, we have our expectations. And somebody brings great grandma's famous potato salad to the potluck, but they did something to it. It's not the same. It's not consistent. It breaks our expectations and it throws everything off. We expect our labs and our lab values to be in the lab area, not a scanned document someplace in the archives that's not tied into the lab area. And I'm going to use a lot of clinical type examples because that's kind of my default. That's where I go. But you can think of other places, and I invite you to think about how what this talks about applies not just to a lab report. How also does it apply to the things that you do in your area? I kind of looked across and see what areas of work you were when you registered, and we have a wide variety, which I think is awesome. But the thing is we can't come at this as this is clinical, this is financial, this is operational. We're all in it together. So while a lot of my examples might be clinical, simply because that's what I'm most familiar with, there are additional examples of our information being where we expect it to be. Expected to be. How is that data going to be found and used? Course, we have audits, we have OSV, we have all of those things, and we want to make sure that everything is in compliance. And data governance helps us do that. We have protections for our data. We want it to be readily available for us. We want it to be accurate. We don't want to find that our sliding fee scale information is scanned in, but it was never entered in, and so we're out of compliance. That family that should be getting a discount isn't. So those type of things. And then decision making. That is the point of all of our information. It's for making decisions and not just the provider making a decision on what the next care objective is, but that we can make good operational decisions. If we don't have good operational data on what type of visits we're having, or which providers are seeing what types of patients, or who's got no-shows that are killing the schedule. What do we need for this grant application? Is that information somewhere we can get it? Are our financials, are those all lined up with the correct labels and things so we know exactly what things are going on? And one little caveat, I'm very weak on all of the intricacies of the financial side. I work with some amazing people and they take care of those things. So if I slip up on some of the terms around financials, feel free to correct me. I know that is not my strongest suit. So let's get into these just a little bit deeper. You want to advance the slide, Maria? And we'll talk a little bit more about accuracy. So we all know we want our data to be correct. We want it to be accurate. We have to use that for strategy. We use that for, automation. If our information isn't where it needs to be in order to run the clinical rule engine or the billing engine, it's going to put more burden on manual processes. Real-time validation can be done. This is one thing I really recommend with the health centers using Azara and the PVP. That PVP, that patient visit planning report that runs for every day, all the alerts and basic, key points for that patient, that is an amazing real-time audit tool. If there's something wrong on there, staff, and this is how I did it at my health center, when you're done with that, write on it what's wrong so I can fix it. And sometimes fixing it was retraining, but sometimes fixing it really was fixing it. And so use those things to do your mini audits, and we'll get into audits in a minute. Our accuracy really, really strengthens our health center. It strengthens our processes. It strengthens all of our teams. And it gives us, by doing this, an opportunity to continuously train to keep that high level of accuracy. One of the things we need to keep in mind is, who controls the things that change? Codes change every year. Sometimes they change even more often. How is that managed? Who manages that? Are there multiple people that manage that? Is it, oh, we have a problem where our codes are getting denied, we need to go fix something? Are we proactive, reactive? All of that comes into the data governance. Do we need to, we change these codes? Do we need to update a rule? Do we need to update a template? Do we need to fix a macro? Did you update your connections in Azara? Every time something changes in your EHR or something goes in a different place in your EHR, Azara is not going to know what that is unless it's mapped. So if it's not got a code tied to it, you've got to also maintain all of your other additional tools besides your EHR. You've got more than just your EHR going on. If they communicate with each other, you have to make sure that those changes are communicated as well. One of the biggest indicators to me of some gaps in data governance is when there's differences between systems. And when you have a good, accurate process of using your data and bringing it into the system and structuring it, then you do that across the board and it stays consistent and reliable across all of the tools that you use. So how do we monitor this and make sure it's accurate? I said that A word, that audit word, yes. An audit doesn't have to be a big, huge thing. It can be 5 charts. It can be 10 charts. I'm really, with everything as electronic as it is, the computer is going to do the same thing every time. So if you have an element that is inaccurate and you find that, you audit 5, 10 charts and you find that 6 times out of 10, you don't have to keep going. If they're all 6 of those are the same error, that is the problem. You don't have to keep going. That computer is going to do that same thing every time it sees that those 6 ways that it's in there that it's not supposed to be, it's going to do it the same time every time. Once you go fix it, it's going to fix going forward. And remember, the quicker you fix it, the better your data is going to be because it's not necessarily going to go back and retroactively fix it. Lean into that real-time validation. Make sure that your people that are using the data have a good way to be heard when they see something that doesn't look accurate to them. You have your best indicator that this alert's broken or that rule is not running when the people that are using it have something that's kicking back at them. It's like this isn't working like it's supposed to. And then round back to them, hear them, listen to them, what's going on, what are they expecting, go investigate it, check it out, run a couple of chart checks, and then come back. It's like, yep, this is actually the way it needs to be, and what this measure is looking for is XYZ, not ABC, and then do just a little mini training, make sure everybody's on the same page. So that is how we keep our accuracy online, by doing a continuous data governance monitoring process. Next slide, Maria. Security. We are all about security, absolutely 100%. We absolutely need to keep our information safe, but we also need to keep it usable. And this kind of brings into the idea of role-based access. Do you have your EHR roles and staff set to where everybody can see all the information? Or is it narrowed down? They have what they need to know for the population they are taking care of, so that we stay in line with the HIPAA rules around, HIPAA comes down to we are able to access that PHI because we need to know that to do our job duties. And so that is where the critical piece of those job roles is. Are we too narrow that they can't get their job done? We need to make sure that they're aligned to their job tasks. Or is it too broad and they can have access to the entire patient panel, not just the provider they're working with or the location they're working at? So how are you managing that access to stay in line with the need to know standard for HIPAA? How do you manage access to special PHI things such as adolescent reproductive care or substance use treatment? Those type of things can be role-based. They can be set up several different ways. And these are your security pieces around governing the access of that data. Do those also need to be in place and open for those who are entering that data? So there's the data in piece of data governance and security. There's the data use piece for that, and then extracting data for reports, for external audits, and those type of things. So those are all pieces of security around data governance. And one thing that I'm kind of curious about and to see how it develops as we go forward, I've been in healthcare long enough that I'm very familiar with paper medical records. And we would thin the charts. And then after a certain time, those charts were thinned, they were archived, 15 years after for an adult, 15 years, and they were disposed of. How long are we keeping our information in our EHRs? Are we keeping that in perpetuity? And is that creating a risk downstream for us? That's something I've not really heard a lot about. So I'm just throwing that out there because it's something that's kind of been niggling in the back of my mind, is like, how are we doing our data governance long-term overall and disposing of data like that, not just are we securely disposing of the hard drives off of this system or that system? So I don't have answers for that. Consistency in the workflow. This is, to me, one of the most critical pieces of your data governance program, because so much comes back to the workflow. If our workflow is uniform, consistent, our same data is going in our system in the same place with the same labels in the same way, our data set is consistent, it's uniform, and it's very, very usable. When those workflows get broken or they get inconsistent in the data being input, when we have our demographics come in, Are our demographics being entered into the system the same way every time? Do we have everything going into those discrete fields, or is there a process somewhere that it's kind of bypassing that? And when every employee follows the same process for that data, sometimes you might need to change up the people part of the workflow. Sometimes the architecture of a building or the design of a team makes the people side of the workflow slightly different, but that data side of the workflow, because there's two sides to the workflow. There's the person doing it and there's the data piece of it. That data piece, the more consistent and reliable and uniform that data workflow is, the better your data is going to be, the more reliable and consistent and robust your data is going to be. When things get messy in the workflows, then things get messy in the data set. And then when things are messy in the data set, they're not as uniform and usable. So we really, really want to have our uniform, predictable workflow for reliable data, high quality data, so that we can use that confidently in our grant applications, in our patient safety committee, in our interactions with the board, with the public, with the patients. And so that consistency is so important. Some examples of this, registration or checking in. Come up to the desk, is your phone number the same? Yep. Well, it's the same for the patient because they haven't realized they haven't been in a year, but their phone number's changed 3 times. A change in the people side of that process. Is your phone number still ending in ABCD? Now, I get that at the pharmacy all the time, and I always have to run through my whole phone number to make sure that that's the right number. But it makes me stop and think, is that the right phone number for this account? And sometimes I get confused because I might be picking up for one of my kids or something. It's like, which phone number am I using today? That's the point, though. Think about that phone number because that is a vital communication line for us with our patients. So that workflow, the people side of that workflow, just how that is worded, it creates a more robust and reliable data set in the phone numbers. Another example, front desk demographics registration. Patient comes in, Kathy Smith. Okay, put them in the computer, Kathy Smith, everything's in. They put all their information in online. They put their insurance card in online. You're good to go. Go through the visit, send it off to the insurance. We didn't check that patient's ID. She goes by Kathy, but her name is Catherine. Insurance kicks it back. Name mismatch. Have to go back and fix it. Checking that ID up front to make sure that the name on the account, the name on the ID, the name on the insurance card saves time on the back end. Not just having to fix that record or fix that claim, but also that kickback of that claim didn't bring our revenue in on time. So it has that impact as well. So setting those thoughtful processes for our people centered around our consistent processes with our data ensures that all of the information that we have in all of our systems is consistent, reliable, and up to date. A simple way to do an audit for this, you don't have to go and pull 30 charts and compare and make sure that the ID was scanned in and it matches everything. You can just stand and listen. Stand and listen at different times of the week or times of the day, and you can hear these things. You can pick up on it. You can do real quick. It's like, need to make sure we use that script. Oh, well, that's my friend. Okay, that's cool. Can you go ahead and use the script so you keep your habits and she has, as a patient, a consistent experience of what happens when she comes in? Real simple. Nobody's in trouble. Just kind of a readjust. We have to readjust and shift all the time. And having that consistent feedback in the people side and the data side keeps things clean and consistent going forward. A clinical example, a patient comes in, they bring a printed report, they went and they had an MRI or they saw a specialist or they had labs done at an outside lab that you're not affiliated with. They bring them with us. Provider looks at it, awesome, sets it on the provider's desk. Provider does what provider does. Staff does what staff does. A couple weeks later, provider's like, hey, this needs to go to scanning. It's been sitting on my desk. Nurse is busy, MA is busy. It sits on the nurse's desk for a couple days a week. Finally, it makes its way to medical records or health information management, whichever department name you use, and it gets added to the stack. And they get through that stack. It's 2 months later. In the meantime, provider's not seeing it in the record, so the provider's having the support staff, hey, call and get that report because she forgot it's buried on her desk. Or he call, get that. The other end of the line, they send it over, no problem. It comes in, it goes through the queue, medical records puts it in, got it, provider does their thing. It's in there. But then it comes through again in the scanning stack. So we've increased our burden on our staff because there's not a set process for what do we do with stuff that comes in on paper that needs to get put in the chart. Um, so it set around a little bit. And then our clinical staff did follow up to get that into the electronic record. Medical records processed it as it came in, both electronically and on paper. So it's a little thing, but those can add up. And so having consistent planned entry routes for every piece of data streamlines things and gets things in with less work. And then, did you notice we have that report in there twice? There's duplication, which, if there's just a few things in that section of the chart, okay, but if you have duplication after duplication after duplication, things get messy, things get hard to find, care slows down because what you are looking for and what you need can't be found. All right. Processes. So I just want to sit here and think, how does this work in your health center? Where are areas that you want to go and take a look at? And this is not a one and done. This is not a yearly checkup. This is a continuous ongoing process because our data is coming in every day. We're using our data every day. We have to maintain it every day. And so this is a strategy. Map it out. When do we need to check our documentation templates? Do we need to shift more to templates that will drop things in? Do we need to spend a few minutes setting up some macros? Sometimes you have to invest some time up front for efficiency on the backside. And that can be hard to do when you're in the middle of the chaos and everything's happening. So strategize it, plan it. Put it down the road a little bit, but put it on the roadmap. What about your forms? Are your forms Franken forms? You've had this form, you started with it 15 years ago, and you've added this and changed this and updated that and tweaked this, and we have a new requirement for that. Does your form need a complete revamp? Or is it good? You've been keeping up on it, it's all kind of consistent and it looks good. That's good. That's cool. Are we making sure that we're not duplicating things? Do we have an intake form and a screening form and a new patient form and a history form and three of those ask the same question? Do we need to take a look at that? What are all of our processes around data going into the system across the entire health center? Do we have any oversight to that? That's the first place to start. What oversight do we have of who's putting in what and where's it going? So that's the first step in building this if you don't have a robust system. What about our access controls? Have we started as a small clinic and gotten larger and all of our clinical staff have access to all the things, but now we're in 3 locations with 15 provider teams, and maybe we need to take a look at that and narrow that access down. Maybe you have a lot of floaters. Maybe everybody goes to all the health centers and you're good. Assess it, document it, you're good. Do you have a standardized process for reviewing all of your things? Put it on your roadmap. If you don't have it, put making it on your roadmap. And then when you're making it, roadmap when you're going to put it. This, if is not already something inherent to your health center, this is huge. It can't be done overnight. It can't be done in a month. And it's an ongoing long-term thing. Build it as you mean to go on, and that takes some time. Documentation and coding. I'm a nurse. I know all about documentation. If it's not documented, it's not done. Coding, I am grateful that we have Maria on staff because coding is not my strong suit. But I know Maria cannot code my chart unless I have good documentation in there. And so those tie together. Coding is just the numerification of my words. And so those have to go together, they have to match, and they have to meet the legal requirements or the oversight requirements. And we do this by having regular audits. We have regular formal audits, but we also, every time something kicks back as an error, that's an opportunity to do a mini audit. Is it a one of? Is it a oops, something's broke? Is it oops, something changed? Oh, it was just a fat finger. Cool. Everybody does that. No worries. Or do we need to retrain? So every time you get something kicked back or something that's not expected, that's an opportunity for a realignment. You know, keep it tight, keep it consistent, keep it reliable. And then lack of these checks can let little things filter in, and then they become bigger things, and then huge things, and then you have an event. Is it a care event? Is it an audit finding? Is it an OSV finding? What is it? Is it a security issue? A lot of times it's really easy for us to put these off to the side because we have a patient in front of us, we have an administrator in front of us, we have a provider in front of us, we have a peer in front of us that needs something right now. And those ongoing maintenance things kind of slide off to the side. And we can do that for a little while. We can do that in a crunch, but we can't let it become consistent because then we end up at square one where we need to rebuild everything all over again as we're trying to fly the plane, drive the car, navigate the boat. So, what on this slide, what is your one takeaway from this today? That we're not done yet, but I'm gonna have you think here. What on this slide is something you need or want to check on this week? What is one thing on this slide you want to check on this week? Doesn't have to fix it, but where do you want to start? Okay. Maria, next slide. Oh, we have chat. I love when people start talking in the chat. If anyone has policies, draft policies, would love to see that. We would love to see that too. We can put that out in the repository. That would be awesome. I am a firm believer in if somebody else has built it, why should I start from scratch? People have awesome ideas. Um, Start with all of it. It is so hard to start with all of it, and that's a little bit of why I suggested pick one, because you got to start with one. Which one do you want to start with? Review the chart audit frequency policy and the number of charts reviewed. That's awesome. Yes. Got to start somewhere. Start with access. Who's got access to what and what do they need? Yes. That can get away from you if your clinic is growing or it's not been looked at. It's like, where's your access at? Excellent. Thank you guys for engaging in the chat. That's some great ideas. And take note of the other people on the chat. These are your teammates. Reach out to each other or through us. We're always happy to facilitate, but you don't have to go through us if you have a direct connection. Documentation quality checks. A process removing templates from the past and rebuilding them that are public or private to different providers. Yes, those templates can get messy. We had, and I might be telling tales out of school, but it's been long enough that this should be okay. We had a template, and I did not touch the provider's template. I've been an old school nurse. I don't touch providers' templates because I that's just a a line that I was used to having. And we had a template. It's like, okay, these are what we need for this measure in UDS to meet this particular criteria. UDS changed. I didn't change templates. Not only was it a line that, that was not something that Heather did, that was something that my access and my role didn't allow. So it wasn't just me not doing it. For an entire year, that template got used, and that UDS measure went from very good to not so good, just because there was a template that didn't get updated. And the thing with that is you can update that template in September, and then the rest of the year it's capturing it right. But from September backwards to January, those don't fix retroactively. So the quicker you can get on those, the better those are. Let's see. Sometimes we gather information for a project and forget to remove that when the project wraps up and the data is no longer needed. Yes, data life cycle. And I think Maria is going to get to that later, but data life cycle, and that's a little bit of where I'm coming from on the how long and how much information do we keep in our charts now that it's electronic, as opposed to having a physical space to keep our physical charts. We've got unlimited, quote unquote, unlimited electronic storage. We can keep it all. Should we keep it all? And if not, how do we do that? So, that data life cycle. All right. Keep going in the chat. I love it. I'm going to continue on with this slide. Talks a little bit about what we've been talking about, but just kind of brings it in a little closer. We have inconsistent workflows can make a variation in how a diagnosis is rendered or how it is input, on procedures, how outcomes are recorded. Are these things going in as structured data? Does somebody have a macro that's dropping things in? Does somebody else have it in free text? How are we doing those pieces of workflow? Delays in documentation. The example of the scanned in document. Now that came in, the provider saw it, he had it. We didn't really have a care concern around that. That was more of an administrative burden piece. But we can also have delays in things coming in. That queue of incoming data gets bloated and we don't see something that comes in that should be flagged. That can be a concern. Or we have some history that's scanned into the chart in a folder for past history that's not been abstracted or entered anywhere into the PHI that the provider can see when you pull it up. We're looking at it, what's going on, what do I need to think of for this, that, and the other thing, and these meds and this diagnosis and what I'm seeing in front of me. And there's a key piece of information that's scanned in that provider is responsible for including in their decision making, but it's not readily accessible. That's a concern. Do we have efficient, specific workflows that support getting that old chart that comes over, get that abstracted? Talked a little bit about role-based access and then workflows around sensitive patient information. What about escalating and correcting processes that are concerned? Do you have a pipeline, a reporting pipeline that is there, that feels safe, feels supportive for staff to say, hey, is this the way this is supposed to be? Because it's doing this and that doesn't make sense to me. Do we answer their question? Do we give them reassurance? Like, yep, I see what you're saying. This is doing XYZ because we need to have that for our audit. What do you have concerns about the data usage or the data storage? Are there concerns around that? Or is it just, it's something new? So kind of see where they're coming from, because your people that are working with that information are your best, canary in the mine? They're going to be the ones that is like, this isn't working, something doesn't feel right. And that gut instinct is so important, because what that really is we're recognizing a pattern and we're applying our lived experience to that, and something is triggering this is off. And so listen to that. Our staff are very good and they're very intuitive and they can work, we can work together to see these things and adjust our data policies and processes to ensure that everything is where it needs to be and reliable. And then we all know that coding on our care activities, it'll make or break us. If that's not right, we're getting kickbacks, it's going to affect our revenue. It's going to affect our manual work time for correcting those or collections. Or what about we have an audit? What if we have a recoupment? We do not want to get in that situation. So these are all things that are impacted by data governance because data governance is everything around our data, input, use, storage, access. And now we'll move on to compliance. Part of we all, I know, we all have data security, data compliance policies. That's part of our data governance because keeping that data safe, secure, and protected is part of ensuring that we have accurate, reliable, consistent, and available data for our work. So we all have processes that we go through every year. Or I shouldn't say all. Most of us we do a security risk assessment. The HCCN is here to help and support with that with some tools. We're here to support all health centers if you have questions as you go into those processes. Trish, Maria, and I have done a multitude of different assessments and picking apart those things. Sometimes it helps to have an outside view. It's very common for Trish or Maria and I to reach out and say, what do you think about this? Or have you seen that? We're here to do that for you guys too. So when you're looking at your data, you have questions around, is this what I should be doing? There's resources. There's also excellent resources in the membership. We've got some very, very robust and tested IT security folks in our network that are a resource for if you have questions. Because I know all of you guys are great about collaborating, but sometimes that's not something that we have a go-to to think about reaching out and asking, hey, how do you do this? Or what protections do you do for that? Or what encryption model are you using? Those type of things. We know that we need to do it for a HIPAA perspective. We know we need to do it because of 42 CFR. We know we need to do it because legally we need to do it. But we also need to make sure that our patients feel safe trusting us with their information. Because if they don't trust us with their information, what are they maybe not telling us? What do they maybe not want in that chart for for a partner or a parent or a caregiver to see? So, you know, are there ways that we can make sure that we have our data protected, our patients trust us, and we have complete data? This could be a whole entire series on its own. If you have further questions about data security, compliance, protection, let us know. We can get you some information on that, but I don't want to get too deep into this aspect of data governance. I tend to get long-winded. Maria's got some more slides coming up, and I see we have, I'm taking up all the time. Sorry, Maria. Decision making. So we use our data to make decisions. But we also need to make decisions about our data. So I kind of think back to now this is going back to paper. I'm dating myself. We used to have a forms committee. Anybody remember the forms committee where you would come together and you would look at what do we need to change on this form or what do we need to change on this pre-op data set? And you'd come together and you would have a meeting of the minds and everybody would work together to make sure that this new updated form of whichever format it is meets everybody's needs, doesn't break something that somebody else is using and is in compliance. Do we have that for our electronic data governance? And if not, I strongly encourage you to consider the application of that as appropriate to whatever you're working on. Nothing is worse than having something in the system and expecting to be able to pull a report, but somebody changed your form and that data field's no longer there. That never happened to me, but it might have happened to maybe one of you out there. So as we make these changes, it's always kind of good to stop and make sure that there's not something in there that somebody else is using or that somebody needs for their grant report or their audit or something like that. Um, so that's just kind of a throwback of something that was useful in the paper era that we might want to consider as appropriate for what we're working on in our electronic health record. And Maria, I left you with very little time, but I will let you do your section.
You are good. Thank you so much. I think I learn more from Heather than everybody else does sometimes. So when it comes to governance, so we've gone over what the data, what we need to do with the data, how we need to keep it accurate, what the consistent process is. But now it's who is involved in this, right? In essence, everybody in your health center is involved. That is your compliance teams, your IT department for sure. And I see I've got Dustin and I think I got Keith on here. And they know firsthand that, if your IT department is the administrator of your EHR, you know that they're the ones that need to be players in data governance. If not, who is that person that owns that role, right? Is it your operations person, your data analysts, anybody that's running reports, your architects, your stewards, who owns your data, right? The owners of the data. So that's kind of like who is involved in this. Um, and it's a little bit of everybody, right? Who owns the data? Who has the overall responsibility for data sets or workflows? Who makes the decisions? Who can have access to what? Your consumers, the end users, and everybody at one point or another can be an end user or has been an end user, and they're relying on this data, right? Heather stated your front desk staff. I'm an eClinical Works super user, and so I use eClinical Works kind of in the back of my brain. Validating addresses, right? Little things like that. If you don't validate the address for accuracy of your data, what happens? I can tell you that your billing team uses addresses all the time to send out statements. So if the address isn't correct because you didn't validate it, maybe the statement comes back and now you're delaying payment. So everything works together. Your stewards, these are your management kind of roles, responsible for maintaining things, and the sets of data. They make sure quality standards are met. Your quality, your QI department, your QI person at your clinic that is the director of your quality assurance projects and things like that. How are they appropriately using your data? The architect, right? Who's designing this? Let's go back to the IT kind of area or your HIT. Who's developing the templates? Do you have all your providers just developing any templates that they want, or do you have it structured down to where you have templates that all providers use for your health center? Where is that design team coming from? Who's your reporters? Your data analysts? Who's reporting on the data? Usually your reporters, if they are clinical mindset, they're going to know if something looks a little fishy, whether it be based on visit types or facilities or what's the difference. So really rely on those data analysts to know that every time they're reporting, it's kind of a mini audit, right? They're finding out where the problems are. Your compliance and legal teams, this is your risk stratification, your risk management. Do you have an incident reporting module that you use, whether that be insufficient data audits in the system, or if that's a near miss, or what's that process? Does that involve everybody? I again say your information technology department, and that's because I think they really play a crucial role in the structure of your EMR and some of those processes that you have electronically. Especially with AI coming out, you really want to rely on your IT people or your HIT people to help guide you through some of that compliance. And then final, your governance committee. So just like your board has finance committees or executive committees in your board, and you should always have or think about having a governance committee. And this can be everybody from your C-suite down to your front desk managers. More of that middle management, high level. These are your decision makers. We've already gone decision making, but everybody needs to come to the sandbox. We all have to be here to make our data compliant, accurate, and the communication is the better the communication, the better we work, right? And like I said, that's everything from clinical, dental, vision, and RCM. So how does your role affect the data? We all have those employees that think that because my skill and experience is higher than others, that should make my input maybe better. And it depends on the size of your organization. With skills and experience, I use, an RN, right? There's so many floor staff. So you could, as an FQHC and RHC, you could have CNAs, MAs, LPNs, RNs, all be working the floor. So where's that experience? How's that workflow? How does one person's job on the floor staff work towards another person's? Authority. Are you middle management? Do you have the authority to make decisions about your data? Make sure if we do, that needs to go to the governance committee. That definitely needs to be communicated through all parts of the health center. Collaboration and communication is probably the number one thing. Without great communication, things can fall through the caps. And that is company-wide. When I was at the clinic level, I had great communication between my billing department, my CFO, my CEO. I mean, we had great communication down to the clinic level and the front desk staff. And where's the problem, right? Where was the problem if we were having problems with reporting? So make sure that we stay in communication with every parts of our health center. Evaluate your data. Evaluate in small meetings. If you have a quality improvement group that you're meeting with, evaluate the data that you're striving for with a QI plan or a project that you have. Make sure we're flexible. So everybody has an idea of what something should be. And our ideas might be different. They might have the same output or outcome, but be flexible in workflows. Be flexible with what staff is involved with what, because every opinion matters. Roles in the EMR versus roles as an employee, huge, right? So you might have 10 roles in the EMR, and I'm being on the lighter side of that. But you might have 20 or 25 roles as an employee. So what roles as an employee, how does that function in the electronic medical record? So where does that play? That can also go into job descriptions. And then you have your super users, which I definitely think are very important. Super users have their place in the training module. You can have super users from providers to nurses to front desk staff, but they're the reliable. They've been on the system the longest. They know the procedures. They're more accurate. Use your staff in an appropriate way. I use this with a lot of my clinics. I say, work smarter, not harder. And super users is it. They're a definite boost when it comes to accuracy and training. The Data Governance Committee. So the Data Governance Committee is a committee essential for every organization. It ensures compliance with data, regulations. It keeps everybody on the same page. They ensure data quality. If you have an EMR that something came out where there's a new update coming out, you don't want to just do the update. Is that your HIT, decision making? That should be everybody. That is what needs to go to the Data Governance Committee. Is there a new module that's out? How much does it cost? Who's going to use it? where's the updates? Is there, revenue cycle management updates, or do we need to automate things? Like I said, work smarter, not harder, or we're doing automations of our data. What is going to be the most compliance? This data governance committee, like I said, is C-suite. It's middle management, and it's directors of every single department in your organization. It should probably meet once a month just to keep everybody on the same page because we know how fast technology works. I did a little thing on artificial intelligence, and everybody's, thinking, "Oh Lord, AI. Let's do ambient listening and scribe, and let's set up everything for AI for the phones." And everybody's kind of has these newfangled things, and it's kind of overwhelming. But let's drill it down. All these AI principles, they're not new, right? We're doing them every day, just on a different format. And they have to have a governance foundation to exist. So it extends the already existing principles of the thing. We're already doing this for AI, right? It's just at a different level. So what data are you doing with AI? What's involved in this? What of our data is accurate and reliable and consistent in the AI model? Is it classified correctly, right? Like for AI, the need to know information, right? Everybody doesn't need to know that I had an appointment today or that what that appointment entailed, right? So there's need to know information. And then who's accountable for this? Who's watching AI? Who's doing this? Cybersecurity, things like that. Who encompasses the security for AI and watches out for our data? And is it viable or can it be destroyed? Heather was talking about paper charts. I swear I've got too much trauma when it comes to paper charts. But how did is the data destroyable? We went from EHS. A lot of us went from EHS back in 2019 when it decided to go away. And it forced us into, okay, where are we going to go from here? Or EHS back in 2014, 2015 became too minimal, and we needed another EMR program that was more robust with our data. So you all had this EMR that either was at a read-only or it was archived, right? So when can we get rid of that? What's the state law for Kansas? 10 years for medical, right? Depending on birth. But, when can we get rid of this data? And AI consumes all types of data, whether it be clinical data or, your revenue cycle management data. What data is that encompassing? And how do you distinguish between it? And then the data life cycle, and I'm kind of rushing a little bit. It kind of goes along with that, right? From start to finish, how we collect, how we process the data, where we're using it and storing it, how we archive it, and then to the point of destruction. Do we have policies and procedures that go over all of this? Because we should, right? There should. And yes, some of them have to follow the state guidelines or federal guidelines for that matter. Usually state's a little higher. But we should have policies and procedures going over our data life cycle. If we collect the data from patient level and then destroy the data after it's time that they haven't been back, or how are we reusing the data that we had instead of destroying it? Like Trish had put something, if we're collecting the data now and we don't need it anymore, I know from an EMR standpoint that I can't just click delete, right? I'm not deleting anything. But if I don't need to use that structured data element anymore, let's push it back down to the bottom, get it out of everybody's way, and go from there. How are we reusing that kind of data? Next steps, and I know Heather, chime in on all this. Develop and review your data source inventory. Know what you have at your health center. Make sure it's complete and accurate. We've gone over accuracy. Include the who. Who are we doing this for? Who is incorporated in this? And then who's the source? Include the assessment. I think we were talking a lot about, I see Dawn on here, and it just reminds me every time. we were talking about accuracy and things like that of coding. Let's think of the partners that we have with the farm workers program, with EDW, with Wise Woman. If our data is not accurate and our data is going to them, how is this affecting them also, right? Um, they have their own processes, but it has to rely on our process. So think about that also. Think about how the data and the documentation and the coding is going to our partners like farm workers, like EDW. We routinely I cannot speak. We routinely train our staff because we have to, right? HR usually does that. They send trainings out. I know that I get emails every once in a while from the IT department saying, "Hey, take this training." Take that model and move it to our clinical staff. If you don't have monthly meetings with your clinical staff, maybe you should. Provider meetings, nursing meetings, front desk, separate these people out, bring them together and have a full meeting. We always need to be training our staff. We're always learning new tools. And then identify the members of your data governance committee. Know who you're going to ask, know who's on there. Maybe you need more, maybe you need less, but it's whatever's comfortable for your organization. And then when making decisions, document the data sources. I worked at a health center that redid their fee schedule. And if she was on here, she would tell you it was trauma filled and hard, and we cried, and it was hard. But now she's got Excel spreadsheets with a date, right? We have updated this debt where here's the date it was updated. If we update it anymore, we're going to update the date on here. And so we can kind of follow that trend. So know your data master. We're creating a data dictionary here at CCNK, and we're going to put it on the repository. And then every year we're going to update it, just like the billing manuals and things like that. So have a data master if you need to when it comes to fee schedules or templates or something like that. So not only do we have it now, but in 5 years, we're going to know where we came from, right? I know we run over a little bit. Is there any questions or comments that we have that anybody needs, and we're always here for help. So you can always email us, Heather, me, Terry, Trish. We're always here for any kind of advice or help that you might have when it comes to get data governance or where your data's at or how to start a data governance committee.
Hey Maria, this is Trish, and I would mention that Carrie did post the evaluation link, and so if you all could make sure to do that, it helps us evaluate our training. Um,
Well, I know it's a little past 11. I hope you all got as much out of this as we got out of, presenting it. We're always learning. And I know that we respect all of your health centers and your workflows, and we're always learning from you. So hopefully you have a wonderful afternoon and a great rest of your week. And if you have any questions, please let us know. The evaluation is in the chat, and we will see you later. Thank you.